Hello, everyone. Thank you for joining us today. I've got a very special guest for you, and we're going to dive deep into some very difficult dental questions today. Someone that's very experienced at answering dental questions, Dr. Mark Burhenne. Thank you so much for joining me, Mark.
Thanks, Stephen. Thanks for having me. This is a long time coming. We've known each other for at least, 4 or 5 years?
Yeah, exactly. We've been talking about, and you've been talking about this, mouth-body connection for a very long time, which is what led, to me to look into your work. I thought that for those of my audience that didn't know yours, that we could go back into, you're a dentist that's been practicing and trying to educate people about, how the mouth connects to the body for quite a long time now. And, when we met, I think it was 2016, and we had breakfast at your house. You were telling me, how you first started to, write these dental queries on the internet, which was quite, early on, early in terms of the days of websites. Can you take us back a little bit into that story and how you kind of got into educating people about their oral health?
Stephen, how far do you want to go back? I had a website. Yeah, I had before AskTheDentist.com. I had a website called the virtual-dentist.com, and that was pretty ugly. I have to say that was tough. I was just writing on my own, but it did win awards, and it was a lot of fun. But as far as it's similar to what your journey is. You're younger than I am, obviously, but when we met in 2016, thanks for remembering that. I was a little jealous because you were talking. You were on a functional health pilgrimage, essentially. You were traveling the world. That's what you told me. And because you were questioning your education, your dental education, the same education I got, except it was 38 years ago. And that's the problem. It hasn't changed that much. And we've talked about it since. And I think every practitioner, if they're willing to do this and to look bigger picture, go more global, really be able to help their patients, they need to think more than what they've been trained to do. And I think that's what you've been doing. That's what I've been doing. Part of being a physician, dentist, healthcare provider is teaching. That's where the Latin root of the verb to doctor comes from. It's actually to teach. Healing is secondary to that. But we can heal by teaching. So yeah, I had kids at the time, so I couldn't join you on your pilgrimage. But now,
do another one, right?
Yeah, exactly. Maybe that's a good idea. There are a lot of great breathing experts all over the world, and it'd be fun to visit them. But now you've got children, so you're going to see it up front. I have a grandchild, and you're seeing now. And I know we've talked about our personal stories. I have breathing issues. You have breathing issues. Most of us do, for a variety of reasons, which I'm sure we'll talk about now. But it's interesting to see it from birth, because of course we don't remember our younger years. But to be able to see it in your children, to be able to see it with my children. Back then I didn't know as much as I do now. But with the grandchild, it's very interesting to see how important those first few moments are, even before you come out of the womb. There's just so much to digest and know about, and it's a little overwhelming for parents. As a grandfather, I'm overwhelmed. I can't imagine what my kids are going through, having kids. So anyway, it's an amazing to be able to expand your knowledge base after a graduate postdoc program is really so important, because you can never stop learning. It's like golf or fly fishing. You never become an expert.
Yeah, I totally agree. And it's funny, actually, reminding about like the times that we met. And, I was really kind of diving into a lot of different, medical, approaches around the world and trying to understand it and how it goes back to the mouth. And, our conversations always kind of come back to this point. It's like everyone's kind of missing how important our teeth are and what is, oral health is really trying to tell us. And you've been doing this for a long time now. I wanted to try and help people understand, or, see your perspective on how this is changing and evolving. And, because you practice for many years. Now, how many years did you practice?
38 years.
Yeah. So that's a long time. There's so much change. So Yeah, take us back into kind of your early days of dental practice and how kind of, these early kind of, signs started to show up, and where you were led on that journey.
Yeah, so I was trained in the U.S., and that's a great dental training. We're great. Most dentists are absolutely like Western medicine physicians are. We're great at fixing things. A sign, a symptom, a fractured tooth, infected tooth, cavities, gum disease. That's a little tougher. It's we're great clinicians. We come out of school and we can solve a lot of issues, but we're really not fixing the real issue. And that issue is what caused all those contributors. These are the kind of root cause contributors and even root causes themselves. And I think that took me a while. I think sleep is what really woke me up, to that whole functional approach. And what is the functional approach? It's basically understanding, instead of just fixing the cavity, it's preventing the cavity and understanding what prevents the cavity, what prevents gum disease. How does gum disease fit into the picture of maybe rheumatoid arthritis or heart disease or even Alzheimer's? Seeing the big picture, and again, the best dentistry is no dentistry, right? Well, how do you do that? Well, you go upstream, you figure out what is causing all of this, why are we not breathing well, what is the root cause there happens to be many dental reasons for that, or at least that fall under the dental profession, the guise of the dental profession. So sleep really kind of did that for me, because I discovered one day in my early 40s that I had sleep apnea, and I knew nothing about it. And then I realized that the physicians I was seeing knew very little about it, and they were just treating, the apneas. And what I'm realizing now, I wrote a book on that whole journey. My wife and I went through that journey, and found it to be very, even as a healthcare professional, both of us, to be very confusing and difficult to get through, and a lot of roadblocks, whether it was utilization from a third party or a physician that just didn't have the training or couldn't recognize things. And as it turns out, dentists can recognize a lot more and things earlier and diagnose, even though we're not supposed to diagnose sleep apnea, but screen for it. We're able to see sleep apnea well before a physician can, because we have a different kind of training. We're looking at different things. So essentially that really kind of brought me to the conclusion that this was difficult for everyone to navigate. And so that's why I wrote the book, The 8-Hour Sleep Paradox. But now, and that was 5-6 years ago, but now I'm realizing that the whole sleep aspect of how we deal with it is very flawed. Like apneas, hypneas, the AHI index, most of that is useless. It really is. Even the term sleep disorder breathing, that always kind of confused me, because is it the sleep that's the issue, or is the breathing that's causing the sleep issue? And so it really should be renamed. And then a lot of the confusion came from the physicians. And I was talking to cardiologists. I was working with physicians now that were doing ablations on some of my patients that had heart arrhythmias, or GERD, for example, regurgitating stomach acids. And I was able to solve a lot of that by taking care of the sleep part of it. And so I was interacting with them and seeing that even though these were brilliant heart surgeons, that a lot of them knew very little about sleep. So that's when I really understood that this is a huge root cause and root contributor to many things dental, many things medical, systemic. We all know how big sleep is. If you don't sleep, you're not just resting, you're trying to fix yourself. You're trying to repair all the damage that's been done during the day. And if you're not doing that, then you're gonna age quickly, and you're going to have a life curve that drops off quickly. You're going to suffer a lot with chronic diseases, probably more than one in your later years. So, and you're going to get a lot of infections and be sick a lot and need a lot of meds. And so sleep is very, very important. And I think that's when I really realized that, and again, this is a root cause that is under the umbrella of dentistry. It's facial development, it's tongue tie, it's oral posture. And so I realized, gosh, my role in healthcare is way bigger than filling cavities and scraping, deep pockets and doing crowns and restoring tooth structure. I mean, that's a noble thing to do. I love doing it. It's an art form, but there's way more to dentistry. And this didn't happen in one moment, Stephen. This was took time, and it was like a pilgrimage, just like what you did. You start connecting all the dots and you start realizing, oh my goodness, usually through a personal story like it happened to me, but you realize that you can do so much more for your patient if you're functionally minded, integratively minded, and you're looking beyond just what is that hole in the tooth. Okay, patient ate a lot of candy, and I mean it's not that simplistic.
It's amazing how the universe has ways of showing you things, right? And you hear a lot of physicians that go through their own personal story that brings them to a whole can of worms that they realize that they never had any kind of real training in. And your story, your book, The 8-Hour Sleep Paradox, was such a great summary, and it still is today. 5 or 6 years later, but as you say, things are moving along so fast. Many people are experiencing what you describe, this sleep problem. Can you tell us about that story? Because, for instance, I see a lot of people. So a lot of husbands are brought in by their wives, and their wives are concerned because they're seeing their husbands snoring, and the husbands are maybe a bit reluctant, or maybe they want to change it but not sure how. Can you describe that scenario a bit, because it is very confusing for people out there?
Well, that was the scenario that I lived through. I was snoring. We were dropping off our oldest daughter to college, and it was the first time we were all in the same room together, the 5 of us, 3 daughters and my wife and I. And of course, I woke up the next morning with my daughters throwing pillows at me, going, "Dad, what was that noise? That was you and snoring." And it turns out it was both of us, my wife and I. So that's a great question, because snoring, and I always thought snoring was funny. It's cute. My dad snored. My mother snored. It just doesn't seem to be a big issue. You tell your physician, "I'm snoring," but nobody would say that to their physician. That just doesn't seem to be a big marker or a big issue, unless you stop breathing, and that's what an apnea is. But of course, you're in deep sleep, coming out of deep sleep. When you stop breathing for 10, 30, 40 seconds, your body wakes you up, but you're kind of like awake, or maybe not awake, partially awake, and you don't remember the apnea, but your airway closed up. That's what medicine measures. But there are so many people, and now I'm seeing them in my practice, that fall through the cracks. And so I started referring out for sleep apnea. Again, as I said, as a dentist, we can see these things early. Bruxism, tongue position, scalloped tongue, facial development, malocclusions. But so I was seeing the sleep apnea, or the sleep disorder breathing, or just recognizing that this person wasn't sleeping optimally. It could be something from severe sleep apnea to something called upper airway resistance syndrome, or even less. These are all the gray areas of sleep disorder breathing. And I was sending them out to the physician, expecting them to prescribe the sleep study, because of course, in the US at least, dentists cannot prescribe the sleep study. And the patient would come back and say, "Dad, they said I was fine." And it was just a verbal conversation. I mean, it was very frustrating. So then I got past that. I got around it. I was able to actually indirectly prescribe a sleep study. And 99% of them, maybe 98% of them, are coming back on the scale of having a sleep disorder issue. There were a few patients that I was convinced, and they were too, because once I described to them what a good night's sleep was, they knew that they weren't getting it. And those patients fall through the cracks because of the medical definition of sleep disruption. You don't have to have a low O2 saturation, for example, to have sleep disruption. You can wake up for a variety of reasons. It doesn't matter. You have a sleep issue if your partner is waking up all the time and thrashing and snoring. I mean, sleep, you have to go through all these stages of sleep. You have to have that proper architecture, and you have to wake up without an alarm clock, usually almost at the exact same time, feeling refreshed. A lot of us don't.
Absolutely. And you probably can look back to that time now and start to see how the symptoms were kind of creeping up. And you see this in patients a lot. When you ask them about sleep, they say, "Oh, I sleep okay." But then you dig a bit deeper and they're like, "Oh, well, I wake up a couple of times and go to the bathroom, or I wake up with a really dry mouth, or, I'm tired in the afternoon," and they just don't think it's an issue.
Right.
Your experience was that your family member discovered it, heard the snoring, which is very common. What was the experience from there? So the family identified an issue. Was it immediately you went to see a physician, or what was the interface that you guys went through from there?
Oh, it's interesting. And you're right. There's a lot of denial, especially with my male patients. I'm male, of course. I was in denial. But in this case, it was my wife. I mean, the next morning in the hotel, there was a continental breakfast before we went out, and we were speaking to someone about it. And he was an elderly gentleman who was on a CPAP. And he said, absolutely, snoring, your husband's snoring, you got to go get him checked. So this is a layperson that understood it at the time. And the irony is that I was one of those male spouses that was told by my wife, you better go in and get that checked. So I mean, yeah, there's a lot of denial. And a lot of people will ask, what is the incidence of sleep apnea? And the old numbers, I call them old numbers because I don't believe them at all, is 6% for women premenopausally, and then, maybe 15 to 18 to 20% for men. I think actually, if you include the whole bundle of sleep issues, not being able to mouth breathing as opposed to nasal breathing, it's going to be about 60, 70% of us. And that happens to be about the same amount of people in my practice at Bruck's, about 50, 60%. And we know that those are related. It's also the same percentage of about people that also can't breathe through their nose properly. So those numbers are similar for a reason, because they're all related. So snoring is definitely something to be concerned about. It's not funny. It's not cute. If you're not snoring, that doesn't mean you're not experiencing interrupted sleep. I want to make that clear. And there are two ends of the spectrum there. If you're not snoring at all, you're probably not able to make that noise by pulling the air in and out of a collapsing or small airway. You're suffering just from severe apneas. And so you go to sleep, it doesn't vibrate, and then you just wake up. And then you do that over and over all night long. Or you may not be snoring. Breathing has to be silent, whether you're asleep or during the day. It has to be absolutely silent. I tell parents that I don't ask for snoring necessarily anymore. I've stopped doing that. I ask them if, is your child making any noise? Can you hear them breathing? If you're in the car next to them or sitting next to them watching TV and you hear them breathing, that's a bad sign. You shouldn't be able to hear anyone breathing. That's the beginning of snoring, essentially.
Absolutely. The daytime signs, when you're looking for them, are really, quite obvious. You can see them, down on the other side of the room
Mm-hmm.
nearly.
Yeah.
Even in the way people stand, you can kind of, you can ascertain as to how they're going to sound when they breathe. And it's interesting when you start to attune to people's breathing, what you notice. For people that are snoring, and you mentioned that there is an advancing now of what we are understanding about the diagnosis of sleep apnea. So at the moment, for people that are snoring and they have a partner that's concerned, they're going to the doctor, they're getting a sleep test. Can you explain? I feel in your book that you gave a really good explanation of this to help people understand, what the tests are and what the terms mean, because it's quite complicated, some of the terms for people to understand and what it's relating to in terms of their sleep. So for example, in the polysomnograph.
So you're talking about the polysomnography, right? So that still is considered to be the gold standard for testing one's sleep. And I fall back on that often still. I have a lot of other ways of checking one's sleep. There are a lot of devices now, personal devices, trackers, there are questionnaires, but the PSG, polysomnography, was invented, I think, in the 60s, and it measures breathing, movement, sleep position, volume of air coming in and out, bruxism. There's an accelerometer that they can put on the chin. It also measures brainwave patterns, which I think is the best part of the PSG. That's something you can't get with a tracker. And brainwave patterns are really the best way to tell what stage of sleep you're in. So unfortunately, this test is very expensive. The insurance companies like to push back on it. Here in the US, it's $2,000 to $3,000. That's for a true attended sleep study. You're in a clinic, someone's watching you remotely. You're hooked up to this equipment. You're in a very nice room that mimics a nice hotel room typically. And it doesn't necessarily just get done once. I mean, sometimes you have to do it multiple times. And that's a lot of money for people. And I think people are upset if they take the test and then, they do well with it. In other words, they don't have sleep apnea. Although I think if you're in the hands of a skilled practitioner, typically, if you're going to get that test, you're going for a reason. So there are apneas. The AHI, which is what everyone talks about. It may just be something that your doctor refers to, your physician, sleep specialist refers to as how many interruptions per hour. What he's referring to is a formula that is scored by someone that has not met you, typically offshore, not in that hospital system. And all these parameters are sent over to them, and then they just put the numbers together. They use the formula, and it spits out a number, and that is the AHI. How many apneas, hypneas? It's an index related to sleep efficiency and time, and that's not accurate. That is really almost a disservice to the patient, because it's not really a reflection, I think, of what's going on. I think really treating sleep requires a lot of hands-on kind of discussions, and that's why a dentist isn't the ideal position. We see our patients way more often. We're able to. It's just set up that way. It's a better system, where in the medical world, it's hard to go see your physician, and maybe you get 15 minutes with them, and so that's a real drawback. So the PSG, I'm not going to say it's bad, because we still need that information. I just wish it was better. I wish it pulled more data. I always have my patients first get something like the Oura Ring. I think that's great data. It doesn't do the brainwave patterns, but it's a great starting point, especially for young people, where they're not overweight, their neck size is fine, but their sleep is not optimal. So start there, find out what the score is. A lot of these trackers, including the Oura Ring, I think the Apple Watch has been compared to the PSG. And they compare. I mean, the statistical difference between the two is negligible. I mean, they're pretty similar. So maybe start there first, and then PSG, those brainwave patterns. That's a great important baseline to get. And remember, as you get older, sleep apnea becomes more prevalent. You can still be thin and healthy, but as you age, your sleep does slowly get worse, and that's normal. But I would encourage everyone to get a good baseline of their sleep in their 20s, and find out, unless you have a sleep issue and it's been identified, then there are many times where I will refer a 1-year-old out to a pediatric ENT or to a sleep specialist. So, but the PSG is still has purpose, but it has to be. I would find someone who can really sit down with you and look at it and interpret it for all its strengths and weaknesses.
I think that's great advice. You've given a perspective on where that data is coming from, the historical perspective of how old the test is and where the technology is now going. And then what we do, because I have a lot of patients that have had tests, and they've been going around to physicians with this piece of paper with this diagnosis of obstructive sleep apnea on it,
Mm-hmm.
and they don't know what to do. They're given the solutions, or so-called solutions,
Mm-hmm.
and there really is, as you say, there's a lot of nuances to it, and that the perspective that you're giving is really that people should take this as a piece of information, and moving forward as to how we can start to fix the whole system, instead of just seeing it as a diagnosis, and there's a one solution.
Yeah, for example, you'll never get a referral to a well, I shouldn't say never, but it would be a big surprise to me if you got a referral to a myofunctional therapist from your physician. And there are many dentists that won't either. But just what you were saying, I mean, you can fix this so many different ways. It's multifactorial. You can't just throw a Cpap at the patient, because we know the compliance of that is very poor. It's 30% after the first year. Oral appliances are a little bit better, but an oral appliance with a Cpap can work as well. There's hybrid therapy, but it could also be something that physicians aren't aware of, that dentists are, and that is the position of the tongue, mouth breathing as opposed to nose breathing. So there are many ways to deal with this. So I tell patients not to look for an absolute. This is such a complicated issue, and hence the treatment is complicated. So you really have to have someone that's looking at the big picture. And it may not just be your dentist. It's certainly not going to be just your physician. It's going to be a group of practitioners, including a myofunctional therapist. I mean, it could be who are the professionals that deal with posture and the cranial sacral.
Sacral therapist, yeah.
Exactly right. I mean, so there are many ways to deal with this, and there's no typically. Occasionally, we get a simple case. A young patient who responds well to an oral appliance, and thankfully, I was one of those patients. I had an AHI of 12, and now I'm 0, and that was verified by PSG. However, I'm still not sleeping perfectly, and that's another story. So I can get good scores on my Oura Ring, but I know, and I mouth tape. I've seen a myofunctional therapist. My oral posture wasn't great. I'm able to nose breathe, but it doesn't come naturally, and that's because of facial development. It's how I developed. It's because of my surroundings when I was born. And my father was a physician, ironically. So I had braces, I had anterior crowding, I had all the things that if I had been born maybe 100, 200 years ago, I would not have.
Which there are probably many that we are still discovering.
Mm-hmm.
Mark, I'm just going to bring up a question from one of the listeners here.
Mm-hmm.
Susan asked, can an adult remove their tonsils? Because I've been told I should have them removed, but told not to have it done. A sleep test was pushed instead, which I passed. And so she's a little bit confused about this scenario. Where do you find this interface between the ear, nose, and throat surgeon and people with potential diagnosis of sleep apnea?
So this is a great question, Susan. This is a classic. This is the majority of the cases I work with. You refer out to one person will say take out the tonsils. One person will say take the tonsils but not the adenoids, or both. Someone will say don't take them out at all. I think what's happening there, and adults can have their tonsils taken out, but it's typically not as common as kids would. It depends on many things. So in this case, if Susan was my patient, I would say, all right, first let's try and get, I assume there's a nasal patency issue here. First, let's get the nose online. Let's do myofunctional therapy. That would not be me. I would refer that out. Force the issue with some mouth taping. Sometimes patients can't do that, but if they can, and they can work through it, you can get that nose back online. You can get the nasal biome up running. You get, once that tissue, that mucosa becomes soft and moist and warm again, and it feels the air rushing through, and then it shrinks a little bit, and then you gain some patency. It opens up a little bit. This is the same for the airway, but nose breathing is how we were meant to do it. I mean, that's, our system evolved where we do the majority of our breathing through our nose. So force that issue first, then maybe get the tonsils taken out if they're in the way physically and you can't shrink them down, and that's where the obstruction is. Yes, you're going to have them taken out. The problem is that a lot of ENTs they have their belief systems. They have these little things that the horses wear, right? And they just won't do it. Also, adults are higher risk. But the newer methods now, robotic surgeries and all that, working in areas that are difficult to get to, it's much improved now. So it's really, patients get confused. And you can't have someone make the decision for you, but you can talk to a lot of professionals and you have to educate yourself, which is difficult to do for some patients, but you really have to get all the facts because there's no one person that has the answer. That's the problem.
Yeah, I love that perspective. And, there certainly is ENTs, they're highly specialized medical professionals. And you're right. They, I think you're describing blinkers. They find things that work and they usually recommend that to patients, but patients are very different. And there are different ways that they express these conditions. So, people that have different diagnoses, for the people that are interfacing in this area, there's usually, we've mentioned the two solutions that are most conventionally recommended. Can you describe them a little bit in terms of how you interface with them in terms of a Cpap machine, and maybe just describe what a Cpap machine does, and then an oral appliance, and how you'd maybe recommend people approach these things, or how we're looking at expanding from them?
Right. That's a great question. It's still an ongoing issue. As a dentist who makes oral appliances, I always ask the patient, let's say they have their diagnosis and we know that there is an obstruction. I try and take it one step further and find out where the obstruction is, whether it's the nasopharynx, velopharynx, and because that has a lot to do with the efficacy of the oral appliance. There's something called the modified Mueller's maneuver. I need an ENT to do that. They do a nasal endoscopy, and they can dangle this little camera above the airway and then constrict the airway so they can only breathe and see where through their mouth and see where the constriction occurs. And that has something to do with the CPAP, APAP as well. But I always want the patient for two reasons. I want them to try the APAP. Usually, if you've had the sleep study and you cross a certain threshold, an AHI of 5 or higher, and again, that number is not that accurate in so many different ways. But for the insurance companies, they're looking for that number, and then they'll pay for the CPAP. And then some patients work well with it. It depends on so many different things. Some people can handle something on their face. Some people can't. People that tend to breathe through their mouth don't like anything over their face, obviously, because they're mouth breathers. If they can't breathe through their nose, these are the same patients that are I don't want to use the word difficult, but are phobic patients. When we're working on them, we're blocking their only airway because they can't breathe through their nose, and they tend to be phobic. It's the same thing with CPAP and APAP. Just having that thing on their face at night, it freaks them out. It may be on for a few hours and they'll rip it off subconsciously. Also having a lot of pressure being blown into your airway. That's how it works. It's taking that airway that as the muscles relax late at night and you go into deep sleep, they lose their tone, that airway will squish together. And as you pull air through it, you'll either snore and get some air through it, or you'll stop breathing. That positive pressure, hence the PAP and CPAP, that's ballooning you out. I mean, it's just creating a higher pressure in that area so that it doesn't collapse. And that can be mildly uncomfortable. I think it affects the lung microbiome, a lot of dry air. It accentuates mouth breathing. Even if it goes through the nose, it's the volume of air, it's the texture, the moisture of the air, the warmth of the air, that's important, but it's the volume of the air and it's the breathing rate. So if you can have a low breathing rate and breathe, 8 to 10 times per minute at night or at rest, that would be optimal. People that wear a CPAP don't do that. It's very difficult for them. It could be the CO2-O2 mix. It could be that they're over-breathing CO2. Then comes the oral appliance. The oral appliance solves the issue by preventing the jaw from falling back, which is also related to deep sleep. The muscles relax, the airway collapses, but the muscles that support the jaw collapse too. And since you're 90 degrees to gravity, it will fall. And that can affect the position of the hyoid bone and several other structures. The tongue, which is not one muscle, it's several. It's 8 muscles. This system here is very complicated, and that airway is as big as a tapioca straw in ideal situations. So a lot can go wrong. But the oral appliance can work well if the obstruction is up higher. And then the oral appliance has higher compliance because people find it more comfortable because there's nothing covering their face, there's nothing blocking their airway. But in both cases, and this is very important, with CPAPs and oral appliances, the efficacy is much, much better. I mean, eminently better if that patient can breathe through their nose. So before I do an oral appliance or do hybrid therapy where it's an oral appliance with a detuned CPAP with less pressure because the airway is being managed partially by preventing it from collapsing with the oral appliance, it's important to be able to breathe through your nose. That's when compliance goes way up. So most of my patients that fail the CPAP mostly men, after 3 months, 60, 90 days, they give up. And they literally just say, okay, well, I'm just going to die sooner and I'm going to suffer, but that's okay because I'm not wearing that CPAP. And that's very frustrating. And the oral appliance is helpful there. But you really have to be, those people that failed the CPAP, APAP, it's typically because they can't breathe through their nose. And I am shocked. And usually they come to me as a last resort. They've seen their physician. And then I just do a quick workup with them. Half hour later, I realize they can't nose breathe. We send them home with some mouth tape. If they fail that test, that's a great differential for me. Obviously, they can't use the CPAP. It's not going to happen. And they may even not be able to wear the oral appliance. They'll be able to wear it, but it won't work as well as if they were able to nose breathe. So I am shocked at how often I see that, where a physician just doesn't address that at all.
Yeah, it's such a it's the uptake of CPAPs are so low, and then those people, like you describe it, they're just thrown into a heap, and they are literally hopeless. So it's such a great point that you bring up, and the approaches to try and the nuances to see if a CPAP is going to be right for a person, or also to the long-term plan. You're going to wear a CPAP for the rest of your life. So there's just so many things for people to consider. Mark, you mentioned the different types of snoring. I think that's interesting for people to. How would you recommend people to start to identify where they're snoring and the different sounds that snoring can
That's
make?
hard. That's really hard. It's even hard as a practitioner. You can snore through the nose. You can snore through the airway. I don't want to say the mouth. I guess you could snore through the mouth. You could get your lips to vibrate a little bit, but that's rare. There's also an important distinction. There's congestion, and then there's anatomical. And as dentists, we can see the anatomical. We can see the lack of proper development. So all we have to do is look at the width of the maxilla, the architecture of the palate. Is it V-shaped? Is it vaulted with a broad, almost flat ceiling at the highest portion? Because that affects the septum. This develops first, then the nose tries to develop. It drops, that septum tries to elongate, and it's gonna crinkle a little bit if this thing is tall, if the palate is tall and V-shaped. So that's where we get these narrow faces, which by the way, everyone thinks is beautiful. They're voted as the most beautiful people in the world, according to some facial surgeons, plastic surgeons in New York. But here's the problem. Because we develop that way, my posterior nasal apertures are probably too small. That's where my breathing rate is probably a little elevated. With my Oura Ring, I measure at about 14 to 15 respirations per minute at night. I wish that was lower. My heart rate is low, it's 49. My sleep, I get a 92. Everything else looks good, but that respiration should be lower. And it's because of these little holes that are behind the palate where the nose gets its air past the base of the skull into the airway. And those probably, I should have them scanned, are narrow. They should be, like walnut, like a almond shaped hole, but they can be narrow because of a narrow maxilla. And that really causes me to snore if I didn't have my oral appliance. What was your question again, Stephen? I wandered a little bit, I think.
Oh, we were just talking about the different areas where there's resistance. So you're describing it well. Yeah.
Okay. So snoring, so if it's congestion, find out what's causing the congestion. If you mouth breathe a lot, then you're pulling a lot of dry air back and forth through this little airway, and that's really not what it was designed to do. And that's going to cause swelling of the mucosa because it's dry, it's irritating it, it's burning it in a way, it's drying it. It's a drying effect. But if you pull that air through the nose with all the baffles, a maze-like journey with ever smaller channels, that collimates the air, that pulls it through slower. You can't overbreathe. If you breathe in through your nose and out through your nose, you cannot overbreathe CO2. That's very important. If you breathe through your mouth, even if you breathe in through your nose and breathe out through your mouth, you're going to overbreathe CO2. And it's really not about O2. We're always getting enough O2. It's because we don't have enough CO2 in the system, and it's the CO2 that tells the system, this breathing system, to release the oxygen to the brain and to the muscles. So, and in dental school, I was told CO2 was a toxin. It's way more complicated than that. So breathing through your nose, take home message. You got to be able to breathe in and breathe out through your nose. That will get rid of the congestion in the nose and in the airway, perhaps. If you have allergies, you have to address that. Find out what that is. That's the epigenetics of breathing. Could be some food, a GMO food or something. Why are our kids all of a sudden allergic to nuts and things in our diet, which causes, that's what anaphylaxis is. That's the extreme. Your airway shuts down. It closes up. Our airway, all the muscles in the airway have the ability to swell up so much that we need someone to cut this open, or we need meds right away to get rid of that reaction. And that's a scary thing. And again, the airway is that big. I don't know if I got it right there. It's smaller than that. I mean, it's tiny. Food goes down that, air has to go through that. And when it collapses, all hell breaks loose.
And you mentioned there's, different contributors to that, and especially one that people are, can get a lot of advice from a good functional dental exam is the bony architecture.
Mm-hmm.
Mark, can you describe a bit? We've gone through it a little bit, but describe so people who are experiencing snoring. Describe some of the things that you will look through in your dental exam that start to give you these warning signs. We've talked about, obviously the width of that palate, which we'll go into a little bit more. Yeah, right. But what are you seeing in the mouth, and what should people look out for in terms of the relationship with the teeth? You mentioned some tongue scalloping. What are these telling you in terms of the risk for snoring?
Right. Well, I mean, from a conversational distance, and I'm, let's say it's a new patient. I want to chat with them for 10, 15 minutes. I want to get to know them. What's their lifestyle like? What are they into? What's causing them stress in their lives? And within minutes, I've already made some assumptions based on facial profile. Is their mouth closed or their lips sealed is the real way to say it. Are their lips sealed when I'm talking? Bags under the eyes? Do they yawn a lot? I mean, there are many ways conversationally, but then once the mouth opens, I mean, for example, if you, and you know all of this, Stephen, I'm going to say it for your readers and viewers, the free margin of the gums, just on the upper anterior teeth. When you see redness and inflammation there, that's typically a mouth breather or very thick plaque. And everything else, as you get further back, is wetter because it's further away from that drying effect. I call that the pole position of free marginal gingivitis. Scalloped tongue, that's the tongue not trying to fight its way into its proper position. You see scalloping of the indent of the tongue on the inside of the teeth, the linguals. You can see a dry tongue. You can see nutritional deficiencies that perhaps are affecting sleep. A very unhealthy tongue. You can see yeast infections in the tongue. That means they're mouth breathing. That relates to sleep apnea, perhaps. It can be other things too. It can be systemic diseases, comorbidities of sleep apnea. Bruxism is the big one in dentistry. The link has not been officially made, but most dentists now that are into sleep practices, have sleep practices, they are looking at bruxism as a functional contributor, or as an indication that this person is thrusting their jaw at night to keep that airway open. And this happens right after the apnea, right as the apnea gets to its peak, and then it ends right after the thrusting of the jaw. So we know it's related in some way. In fact, we've even changed the terminology. We've divided it now into two things. There's daytime grinding, which we still think is stress and occlusion and all that. And now we have sleep bruxism, or nighttime grinding. And that's because it's related to sleep. That's easy to see conversationally. I mean, when you go to a party and you're there, I mean, you're seeing this left and right. You're looking at facial types. You can see it in people. What else? Help me out here, Stephen. You've got a list here.
I think you've hit it really well. And I love the signs of mouth breathing, especially, when they describe, dry mouth, especially, people will, one of the big symptoms are the symptoms around, because some people are quite silent bruxers. I find that they'll describe jaw pain and kind of headaches, just tension around the cheeks.
Yep.
Right. And then that you may not even sometimes pick them up. That their face will actually kind of, you might not see, but then you touch them on the cheek, and then they jump out of the chair nearly because their masseter is so tight, right? And then so there's clenching.
And those are the patients that you can't work on for a long time, because that night or the next day they call you. You had them open for a half hour, even for a cleaning, and they can't stay open because their muscles are so fatigued because they're clenching and grinding all the time. They may not have any TMD or TMJ symptoms. Tonsil stones, that's a perfect example. A lot of mouth breathing. That's visible. What else? I mean, the uvula, the size of the uvula, the little thing that hangs in the back of the at the beginning of the airway, that can be swollen. It can be very red, edematous. That's a sign that it's moving around a lot, that it's obstructing the airway. Also listen to the patient, asking them the right questions. I mean, I don't ask them, how do you sleep? That's the wrong question to ask them. Ask them very pointed questions like, are you ever aware of anything during the middle of the night? Do you ever wake up and check your clock or look out the window to see if it is early morning? Anything like that? Do you ever go to the bathroom in the middle of the night? Does your partner elbow you sometimes? Just ask them directly. Don't ask them if they're sleeping well. Most people will say, of course I'm sleeping well. I feel great.
Absolutely. That's probably about 80-85% of people say that.
Mm-hmm. Yep.
And you kind of take that at face value and then keep
right.
going.
Okay. Next.
Yeah, exactly. The one other thing, Mark, that oral ties are becoming, people are becoming much more aware, and there's a lot of undiagnosed ties. Are you finding, a link in adults who are snoring who had undiagnosed tongue ties or even buccal or lip ties?
Definitely. And first of all, they're being missed even today. And there's the anterior and the posterior tongue tie, but absolutely. And so that's on the checklist. If you see someone who's mouth breathing, you'll see the tongue tie. That, again, oral posture, where you keep that tongue as a child and as you're developing is very, very important. But let's say you make it to adulthood with whatever happened, however you developed, that tongue tie is still an issue for breathing. And for sleeping. And so there have been a lot of patients where we just fix the tongue tie, we refer out to a good surgeon that will take care of it, and the sleeping gets better. So, if you tie down that tongue and it wants to be in a certain position when you're in a relaxed state, atonic state, where your muscles aren't functioning, you got to allow that tongue to move to where it's supposed to be. The tongue is a series of muscles. It only has one attachment. It's the only muscle, I think, in the body. It's like a trunk. It's an elephant trunk. Most muscles have two connection points, and they're working off of a lever system, based, tied to a skeletal system. But the tongue is free range. So you need a good myofunctional therapist to train the tongue because it needs a rest point. It needs to know where to go. But if it's tied down, and you have that little piece of tissue that's holding it in place, you can't stick out your tongue, you can't swallow properly. A lot of people can't swallow big pills, they choke on their food. These are all things that are on my list. A lot of kids can't. I couldn't swallow big pills as a kid. I remember that now. And it probably had to do with that. My granddaughter had a anterior tongue tie that was taken care of immediately after she was born, but then she wasn't latching on. Turns out she had a posterior tongue tie as well that was missed. So tongue ties are tricky, but you want that ability to move your tongue around. You don't want any restriction of the tongue, and for the lip as well, a lip tie. But the tongue tie is the big one.
Yeah, it's part of the diagnostic spectrum, isn't it? And it's so common. Really, kids are still being missed today, but we have this generation of people now who are snoring. It is very common today to have a tie that may not even be that severe, but it's affected the way they use their tongue. And so they can lift their tongue, but they don't get that posterior lifting of the tongue. Right. And that's really what helps support their oropharyngeal area. And a lot of people just don't kind of put those dots together, right? And it's just a part of the picture.
Right. It's a big part of the picture. You're right.
Mark, I wanted to dive into some of the solutions out there now. That we've got a question from the audience, and I'm not sure if you do this kind of treatment, but Sarah asked, what about expanding the airway, so the palate, like something like a Vivos DNA appliance, which is a palatal expansion? I'm not sure if you do this type of treatment, but do you see a modality for this for people with sleep apnea as a potential solution in adults?
Definitely. And I think I kind of changed my thinking on that because, again, falling back on my dental background, you were told you can't change someone once they've developed. And I think that is now is incorrect thinking. And I'm aware of the Vivos DNA appliance. There's so many out there, as you know. I know that you do this in your practice. I refer out for it to an orthodontist. Absolutely. And it's something that I'm thinking of doing personally. Again, back to the posterior nasal apertures. If I mean, and again, we have to measure and what is the correct width of the jaw, and we think we know that well. But absolutely, if you're willing to go through this treatment, and it's not that bad, it's inconvenient. It's not as easy as an Invisalign, and you can't do it with Invisalign. But if you're seeing the right practitioner, then absolutely, this is something that would apply to any adult. I've seen this work. It was an ALF appliance. Was it an ALF or a? I think it was an ALF appliance done by someone who's very well known, and it was done on an 85-year-old. And she was wearing an oral appliance. I referred her, thinking that she didn't really want to do this, but she had an AHI of 54. We got her down to 19 because she wasn't wearing the Cpap. She had a heart condition. I had her promise me that if I got her down with the oral appliance, that she would try the APAP again, which she did. And that's where hybrid therapy works very well. And then a year later, she said, you know what? I'm feeling so great. And maybe she woke up and started thinking straight. This is another problem treating sleepy patients. They're not always thinking straight. And I'm talking about myself when I was tired. You're not the best patient. You're not making the best decisions. And you're not motivated to make these decisions because you're so tired. But she finally said, I want to do this. And the results were amazing. It took 2 years, but this is an 85-year-old woman who definitely had very dense bone and, stopped developing at age 6 or 10. And she was able to expand using an appliance, and she was able to breathe better. And she actually, the long story is, a year later, the AHI with the oral appliance went down to 5, and that was without the Cpap. So again, absolutely amazing story. So it can, at any age, I would look into it, but I wouldn't jump right to it. First try and see if you can fix it with, mouth taping or myofunctional therapy and getting that oral posture right and beginning to breathe right. Start in small steps.
Yeah, there's definitely people that have a very high V-shaped arch that, can be considered. And there's, there are, more drastic surgical interventions too that can help widen. Some practitioners do, but those kind of appliances just slowly expand the palate. I wear one. I've been wearing one on and off now for a couple of years. It's slow going, and it is a little annoying, like you say, but it is relatively easy. I'm actually feeling now, I think I'm probably about, in my current appliance, I'm at about 4 or 5 mil, and I'm starting to feel the back of the back of the soft palate. You can feel the pressure on the muscles as
right.
the bone.
You're stretching.
Yeah, it's stretching.
Plus, you're stretching the soft palate as well, and you can feel that. And of course, you'll stop feeling that eventually. But it is amazing, and 4 to 5 millimeters is a lot. I mean, you don't need to do much.
Well, like when we first met, I always my friends always tease me about being very nasal, when I talk,
right.
and my left nostril is quite collapsed, and I think it's I had a tie when I was younger, didn't breastfeed well, didn't breastfeed, and then so I didn't have this connection of the posterior tongue. I've since learnt this and retrained this nasal breathing, and I feel that I'm starting to improve, or the sound of my voice is starting to change a little bit. I'm still a little bit nasal, but I think there's been some change because of the way the structure is starting to shift. But
I would say that most patients, I mean, what you just described is dead on. It's a slow change, but and you have the knowledge and you can visualize what's happening. But for the layperson, most of the time, I would say 98% of the time, they also say the same thing you do, not as technical and scientific, of course, but they do notice the difference. And that's what's amazing. It's such a small difference, but it makes a world of a difference.
Absolutely. Mark, I wanted to, dive into some of the, the techniques that people can go into to redirect back to nasal breathing. You mentioned, how can we, without practitioner intervention, or what are some of the approaches that we can start to interface? So, for instance, I mouth tape now, but it took me a very long time to be able to tolerate that. How did you go through that? What was that experience for you like, and how would you recommend people approach it?
Right. That's a great question. Trying to remember, I've been mouth taping I want to say about 8 years, but I think I heard about it, and then I mentioned it on a podcast after I tried it, and I did notice a difference. I mean, but being a a scientific person, I was very skeptical, so I kept trying it. It didn't come off. It was very uncomfortable at first. I used the wrong tape, of course, but then they have now specialized tape that is kinder and easier to use. And my wife was trying it as well, and we were discussing it. And then one day I stopped mouth taping, and that's when I noticed the difference. So, and now I can measure the difference with my Oura Ring. I mean, the resting heart rate, respiratory rate, all that gets elevated. It can even affect your sleep interruptions. So there's something definitely going on there. And again, I don't want to say it's the solution for sleep apnea. It certainly isn't. It's really good for people that are in the gray zone, or for some reason they can nose breathe, but they're just not doing that. And that seems to have been me. And of course, when the nose comes online, you start breathing better, and then your daytime breathing may improve. Can't tape during the day. That's not practical. So it was a journey. It wasn't something that happened suddenly until I took it away out of my regimen and nightly sleep regimen. And now, clearly for me, it's something that I cannot do without. My sleep will degrade, even though I'm wearing my oral appliance. I see the difference. So mouth taping is better. I also started thinking that mouth taping, they call it lip taping, which is the better term for it. You're not closing your mouth. You're not sealing off your mouth. This is just a gentle reminder to keep your lips from parting at night. And I want to tell everyone, and I have children in my practice that are mouth taping. They love it. They tell me about how their dreams are better. I mean, it's just amazing. But the minute you force your mouth open, there's no problem. The tape comes off. This is not, again, don't use mouth tape. There is new mouth tape coming out that has a patent on it. I can't talk to you about it now, but there are some very specific products now that are just fantastic. Somnifix has the vented tape. My wife loves that tape. So it's a reminder. It's a gentle reminder, but it's not the fix. The fix, really, all it is an indicator that you're better off nose breathing and that you haven't been nose breathing if you feel the difference. So really, then you have to realize, okay, well, why the heck am I not nose breathing? And why, if I can breathe through my nose, why does my mouth fall open at night? Or if I'm at a stoplight in the car and just waiting for the light to change, why are my lips apart? Why does your child read with their lips apart? These are things that you have to ask. So the mouth tape is just a way to figure this out and to force the issue. And the root cause could be facial development. It could be something where you've learned incorrectly on how to swallow, how to position your tongue, and how to breathe. I think a lot of us think that breathing is guaranteed and innate, right? That we all are good breathers. I would say it's the opposite. Yes, it's guaranteed that we'll take our next breath because the body will find a way to do it, but it's not necessarily the right way. It will accommodate for some inadequacy, whether it's congestion or an anatomical issue, lack of proper breastfeeding. I don't think I breastfed for very long. A tongue tie, all these things that happen due to poor nutrition and development and chewing, gnawing on pureed foods as opposed to good chewy foods as a young person, as an infant. So I think I think mouth taping is something that opened my whole view on this. And I think that's what it is for patients too. But you have to walk them through the process so they know what's going to happen and why it happened. And then what is the next step? And the next step, typically, if you can mouth tape, but then when you take the tape away, and then you revert back, well, then you have to retrain yourself. You have to take care of what the body did back when you were 1 or 2 or 3 years old to stay alive and remap that. And that's why a myofunctional therapist is so important. And I am a firm believer, and I've said this many times, that a dentist that is practicing without a referral route or an in-house myofunctional therapist is practicing below the standard of care.
When you consider how, fundamental these things are to our physiology, to our sleep, to our well-being, it is crazy that these things, haven't been more built into standard dental care. But at the same time, it's very complex. You describe these things so well and so clearly because you've walked the walk for so long. But it is a very hard thing for both practitioners and patients to understand. This is a very complex area that we are still learning so much about. And, I think we're really moving into an area now where the research is kind of starting to come forward, where we know what the absolute detriments of poor sleep will do to us, and then the pathways to how we fix this. You were diagnosed with sleep apnea, right? And now you measure your sleep, and you're breathing quietly through the nose. So this can be done, and I think that's such a powerful message out there. That people, you can reverse this and you can do it. It's not going to be easy, and your pathway hasn't been easy.
No,
but
and I think you're absolutely right. It is, and that's why I wrote the book. It is so complicated and multifactorial that even, and I would tell this to the patient or the viewer, that even your provider probably doesn't fully understand it, unless maybe they've gone through it and they've solved it for themselves. I mean, it requires a lot of education. I really do, and we've talked about this, Stephen, and it's great to be able to talk to you because you get it, and I can talk to other dentists and they'll just roll their eyes and shake their head, or physicians. But I think dentistry is going to have its moment, or it's having its moment. And that's because we have the training for recognizing facial development, early recognition of sleep apnea, which is a root cause for so many things. Nutrition advice. I mean, this lower part of our face is so crucial. I mean, everything hangs from the base of the skull. We've got our airway there. We've got lots of nerves packed in there. And I mean, it really, a physician's world starts at the nasopharynx, maybe even further back at the velopharynx. And really, this is our realm. And we really need to become, I hate to use this word, but physicians of the mouth. But I mean, we already are, but we really need to take charge of this and see the big picture and start going upstream, becoming functional providers like what you do and what you've been preaching for, last 5-10 years, right? I mean, it's straightforward to you, right?
Well, I'm still learning every day. And,
right.
When these kind of conversations with people like you who have devoted their life to really understanding this stuff, and I really appreciate the level of detail, especially, in your book, for instance. I remember, reading, how clear it was. And now that looking back on it, it's because you walk the walk yourself that it became, it was this patient to and self kind of journey, and such an inquisitive mind too. And that's, really what I got to thank you for. That.
Well, thank you.
People that have inquisitive minds, they're going to go deeper and they're going to start to, dig into difficult issues and find solutions, right? And so that's really something that, there's a big opportunity with the mouth that is right in front of us now, as you describe. And I feel that people are waking up to it, right?
Yeah, I agree. And that's why we need to be talking more about this. And it's so important. And I think we need to educate not only physicians and other healthcare practitioners, but also our patients and viewers. Right? Yeah.
Mark, to finish up, you mentioned your grandfather. I thought it'd be interesting to kind of go through what you've seen in terms of, those early, I've got 2 kids under 2 now. And, I'm looking at all this now, and it teaches you every day. What have you learned from being a grandfather and seeing this whole?
That is a great question. And I have learned a lot, and I wish I knew this when I was having kids. It's what I've learned is that it's still difficult to raise a child. Nothing has gotten easier. And I know you're not sleeping as well as you'd like to, having 2, under age 2, but it's interesting to see it from this perspective, and I try and get as involved as possible. But again, as a grandparent, you don't want to get too involved. There's always a little pushback. But my daughter and son-in-law, they both have sleep issues as well. No surprise, right? And so they are open-minded, and they checked for the tongue tie, which unfortunately we had to go back and have a specialist do the surgery. and nutrition has been very important. K2, I wish I had known about K2 as a kid, raising kids. They had a good diet, but it wasn't perfect. So little Quinn, her name is Quinn. She's 3, almost 3. She, her mouth has been closed. She breastfed pretty well. So there was a lot of fine tuning going on. But I'm here to say that don't feel bad. I mean, you and I are always going to be talking about what is the perfect way to raise your kid, what's great for development, and later in the later years for breathing and sleep. And it can get pretty depressing because no one really has a perfect story. And I've seen that with my granddaughter, although she's done well, but there are always things that you have to respond to and you have to look for. So it's important to get really good prenatal advice, perinatal advice. And then of course the postnatal trip is the fun one, but it's very challenging. So far so good. She's got good facial development. She's already seen a orthotropic provider. That's a very forward-thinking orthodontist that, again, my referrals now for kids happen at 1 and 2. We've talked about this. Most dentists in the US will refer maybe at 5 or 6, but typically it's 10 to 13. But again, facial development is pretty much done. The bulk of it, the important stuff is done by age 6. So if you're listening to this now and your child is 5 or 6 or 10, go see the orthodontist now. Get that referral. Don't wait. If you hear your child breathing, if you can hear them breathing, there's an issue. If their lips are parted when they don't need to be parted, get a referral. Seek out someone. On our website, we have a functional provider locator. That you can find a dentist that thinks this way. I'm sure you have resources as well in Australia. And keep listening to podcasts like this. This is very important. And as you said, I'm still learning. And Quinn is a great way to learn. I mean, she's our little test bunny,
Very, very, very stubborn, very heavy-minded teachers, aren't they?
Oh yeah, exactly right. Lots of cod liver oil. She loves it. She likes to eat fish and meat. You just got to keep Weston Price in the back of your head there when you're looking at her and feeding her stuff. But as you know, when she goes to school, she's going to see all the kids eating cheese puffs, and it's going to be tough. It's not easy. And to get them to go to bed after they've looked at an iPad or a TV. I mean, this is not a simple thing in today's world. We've created a real monster, and that is our environment.
Yeah, you really can't downplay the challenge that parents face, can you? And it's we're all learning. But look, it's the wisdom that you've helped people to see in terms of how you practice, and also what you've personally experienced with sleep and breathing interface. I think it's really one of the most important conversations everyone needs to be having with their family members themselves if you're sleeping right. Thank you, Dr. B, so much for spending time with us and sharing your wisdom and all your thoughts. Can you just for those that are looking for practitioners, can you tell them where they can find your database of functional dental practitioners?
Sure.
And where to find you?
Yeah, go to askthedentist.com. That's our website, my daughter and I. And I think it's on the upper right-hand corner, there's a little find a dentist. And it's not just any old dentist. It's a dentist that's been vetted to some degree that they are functionally minded. So and it's been very successful. We only have 100 names, but it's worldwide. And it's been working well. Having that website has been fantastic, and we've been doing it for 10 years. But we created this problem where we educated everyone, and then everyone came to us and said, well, where do I find someone that can talk to me like you were talking to us? And that was the problem. So we're hoping that this helps. And so far, we've gotten a good reception. So.
Well, thank you so much for all the time you've invested into helping people understand this and feeling better. Mark, I hope you have a great day and stay safe in the fires there.
Thank you, Stephen. Always a pleasure. Hope to do this again. Thanks.
Absolutely. We'll have to do it soon.
Okay.
Take care, Mark.
Okay. Bye-bye.